I am honored to be joined by Dr. Marlon Everett. He is a leading cardiologist specializing in interventional cardiology, and he's passionate advocate for heart to health. Dr. Everett has dedicated his career to addressing cardiovascular issues, especially in underserved communities, and works tirelessly to ensure that women's unique needs are recognized in the field of cardiology. Dr. Everett is also, and he's a multi talented person, he's also the CEO of Grace AccuSure Analytical Labs. Dr. Everett, welcome to the show. And I might add, he is my frat brother. He's a member of the world's greatest fraternity, Incorporated, Kappa Alpha Psi. So, with that said, how are you doing, Dr. Everett?
Morning. How are you, Keith?
I'm doing good. Now, before we get started, tell us a little bit about you. Where'd you come from? Because you just didn't show up.
So I grew up in the outside of Chicago. Went to school there. Grew up there. My father was actually a high school principal, and my mother was a high school teacher. So I came from an academic background. Many kids thought that I was going to be a professional basketball player.
Okay.
And and then I quickly realized that by the time I was 13 or 14, that wasn't going to happen. So I started
Okay.
actually being a little bit more focused on sciences, and I was always pretty good in math and science. And I ended up going to Howard University, where I went to undergrad, and that really
Okay.
fostered my career and my passions of really helping people. And ended up on to medical school, and then training at University of Chicago in cardiology. Now
Okay.
I'm now practicing cardiologist really in the same neighborhood I grew up in. It's one of the community hospitals right in my same area. It's in a bigger system, but it's still one of the community hospitals right in the neighborhood I grew up in. So I'm very lucky and blessed to be able to give back to the community that I grew up in.
Yes, you are. And so, very interesting background. There is another connection. We both went to the University of Chicago. So, what led you to the specialization of cardiology? Was it something in the community? Was it what was it? Before we get into some of the more interesting health related questions.
That I was exposed to it pretty early in my medical career. Who was a cardiologist kind of took me under his wing, but back on it, I think a lot of it had to do with the prevalence, especially within
Okay.
African American community. It mentioned all the stats. It's the number one killer. It's the disease that everybody worries about. So it's always
Yes,
kind
it
of
is.
it's the topic at the cocktail dinners or in general. It's the topic that everyone talks about. So the prevalence of it, gravity of the situation, is one of the things that really drove me to it. Understanding that we really have to take care of this and try and reduce the fact that heart disease puts on our people.
So let's start now with the basics. Why do you think heart disease in women remains so unrecognized? And I guess as I think about this and what are some of the unique challenges that women face, I know you as a physician, you probably have a perspective, but I really think women don't even recognize some of the issues. Their families don't recognize it. So why do you think it's so pervasive that way?
I think that the issue is that we have long dismissed disease as a man's disease. Women are pushed to the back because of this, and that's many years. And I would say over the last 25 years, if you look at the data and you look at the graphs, you'll see that the prevalence of heart disease in men has steadily either plateaued or actually decreased,
Yes.
but it rose dramatically within women. I think that we were just wrong. We weren't thinking about it like that. I don't think that there's something that happened any time that made women have it more. They didn't eat different, act different, anything like that. I think we just didn't recognize it. I think the realization of it, on television with the Fred Sanford, I'm having the big one and the big chest pain. And that was always kind of what people thought about. But in reality, we need to do the same thing for women and say, and I'll talk about it a little bit later, their symptoms are a little bit different, but we need to kind of embrace that and to allow women to understand that breast cancer is not really the number one cause women, and it's really going to be heart disease. And we did a great job with breast cancer. Don't get me wrong. I think
Yeah, yeah, yeah.
that now over the last 15 to 20 years, we're realizing that no question about it, heart disease and number one killer in women, and we need to be aware of that.
Now, is it a lifestyle issue? And this is where I'm curious. Is it the foods that they eat? Where is the imbalance here? And how do I mean? Because well, let me stop with just that question. Where's the imbalance?
I think that the imbalance has been there. It's not something that just started. I think that the same imbalance that happens in men happens in women. I tell you that is great. Typically, heart disease doesn't happen in our mothers. So typically, pre-menopausal, you don't have a lot of heart disease. But as soon as a woman hits menopause,
Really?
the age
Okay.
50, 51,
Yeah.
that's when their risk goes almost equivalent to men, and that's what it is. So that's really a God given grace, making sure that our kids don't have heart disease. As soon as they hit menopause and they're no longer able to bear children, when that risk starts to really go up, and we really start to see risk evening out with men.
Wow, I did not know that. That okay, and okay. So there really isn't anything that they can do? I mean, that's an interesting, let's unpack that a little bit. What I'm hearing is the one differentiator between men and women is giving birth. And once that stops, the heart doesn't recognize. Is there any science behind that? What's the
Yeah, I
science
mean
behind that?
I think the science deals with estrogen, progesterone, and those type of imbalances that they have menopausal. But once you start losing the estrogen and progesterone, and the balance changes, that's where the risk starts to come. So that's really where it really kicks in. I think you did kind of allude to something like, can we do to prevent that? Obviously, you can't change your menopause and those type of things. So what you have to do is you have to recognize. I think one of the most important things, and that's why we're doing your podcast and talking about this, is the recognition that you're more likely to die of heart disease than you are of breast cancer. We're very good at mammograms, right? I mean, it's mandated.
Yeah,
It's
we are.
free. Primary care doctor and as a primary care doctor ensures that our women have mammograms every year. We haven't done a great job at making sure our women have heart screening every year. That's where we need to do. That's something that we need to think of.
Okay. And so, let's unpack that a little bit more. And so I have a question about the symptoms of a heart attack. And when I think about heart disease as a layperson, I am thinking high blood pressure. I am thinking anything other than a stroke. Is that the way I should be thinking about it? Because what I found in my research is that the symptoms of a heart attack, as an example, show up very differently in a women than men. Is that true?
Definitely true. That is definitely truth. And in fact, the symptoms, for some odd reason, and this is unclear, and I don't think anyone really knows, some odd reason, symptoms are much more subtle. They're not as classic as the Fred Sanford clutch your chest, I'm having the big one. They're often more subtle, such as a fatigue, yes, pain. One of the biggest masqueraders of heart disease, and this is kind of even with men and women, is going to be the acid reflux type symptoms that you have. I can tell you a story. When I lived in the area where my hospital was, and I lived in a neighborhood on the block, and I was one of my neighbors who was a very cantankerous, kind of a kind of a grumpy old man, I guess you would call him. But he liked me. No one liked him on the block. It was on the block. He didn't like me. So one night he comes to my house because he liked me, and he comes to my house, knocked on about 10:30 at night, and said, "Doc, do you have any more of these acid medications?" I said, "Why?" He brings an empty box of Prilosec that he's holding and saying, I've been taking all these acid medications all night, and for some reason my acid reflux isn't going away. Well, maybe it's not
Wow.
acid reflux. Eddie was his name. May he rest in peace now. But so Eddie, that's might not be acid reflux. That may be something else. So, well, I need to worry about it. And I said, well, come on in the house. Luckily, I brought him in and I talked him out. After a couple minutes, I said, you know what? If we're not going to call the ambulance because I don't think this is acid reflux, at least drive you to the hospital. And he said he agreed to that. I drove him to the hospital. He was actively having a heart attack at that point, and we rushed him to the cath lab and was able to open up one of his arteries because it was 100% blocked off. So that's one of those great masqueraders, and women are I see that often with women as well. This acid reflux symptom, and the way that you know is the acid reflux medicines don't work. I mean, it's pretty
Okay.
simple. If you have to take 30 of them, it's probably not working.
Well, you bring up a really good point. I have the illusion that if you're going to have a heart attack, it's the Fred Stanford style heart attack you're going to have. It's the big one. But what I'm hearing you say is that it's a whole lot more subtle. Very quickly or thoroughly, are there symptoms that the listeners should be thinking about that show up that would make them go to the medical facility? Is it chest
Yeah.
pain? Can you
So
just
I think you're exactly right. I think that since I'm going to start with women because I think the topic is women. Now, the typical symptoms in men
Yes.
are what we talked about: chest discomfort, jaw discomfort. But in women, it's pretty clear, very subtle. And those subtle symptoms may be just a new type of fatigue that you never had, new type
Okay.
of weakness or feeling just down, tired. Pain is another one that not typically that we think for heart attacks, but back pain is one as well. Sweating out any sort of provocation, you're sitting there and starting to sweat. That usually is the sign your body sends a signal to your brain to cause you happy to sweat because your adrenaline is kicking in. You're sitting still, so just
What's interesting about that one is a lot of women, because they think they're going through the menopause component.
that's right, and that's the trick. So many, but realize that once women say it could be medical field, we call it the differential diagnosis. That means that symptom may have multiple reasons, and you have to kind of rule out each one. These podcasts like these, what we're trying to do is trying to say, yes, you may be sweating, and yes, it may be menopause, menopausal symptoms. It may also be something else. And as long as we're thinking about it, that is helpful because that woman may say, this feels different than my normal menopausal sweating. It feels different than my normal menopausal hot flashes, is now associated with a little bit of weakness, fatigue, or maybe I have some back pain. Maybe I have some nausea that's coming with it. Then you have to think you can't attribute it to your normal menopausal flashing, hot flash type symptoms. You're thinking more of maybe it is something different. And then in your brain, you have to say, oh, after listening to the next best thing with Keith Terry, disease is tremendously prevalent in women, and that's the whole objective, is to have people
I
now
see.
have it on your mind. It may not always be right. At least it's on your mind. You have a threshold to call sort of medical facility advice, an ambulance, go to the emergency room, call your physician, whatever. You have a much lower threshold as opposed to just pushing it off to something like menopause.
Yeah, I mean, I just think we should save some lives here because have women in my family who sweat sometimes profusely. They're not in the best shape. And I just thought it was menopause. I just think that, women say, I haven't having a hot flash, and I never thought that it could be related to the heart. And I just think that's a wake up call that folks need to pay attention to. So my next question for you is then, are there preventative steps that people can take? I mean, I guess it's the obvious working out, but are there other things that the healthcare recommend?
I've realized that there is no such thing as obvious. It really isn't. Despite our efforts in society and medicine, government to have more information out there on heart healthy tips, essays, or public service announcements about heart healthiness, I've realized that it's still a large group of people who don't quite understand what is of value and what is not. I think that there's a lot of things that we don't know that are heart healthy, but I can tell you some of the things that we do know that are heart healthy. Know that
Okay.
the number one, I think the biggest issue in my mind is to make sure that you think that you're thinking that you're doing something heart healthy. That's number one. So whatever that is something positive. That's it. So in other words, you got to recognize that smoking cigarettes is not heart healthy. There's a lot of people who
Yes.
don't quite believe in that notion or the data, but the data is pretty clear. Healthiness and cigarettes are on the total opposite of each other. Two is that knowing your numbers. What numbers are we talking about are important. Those numbers include your blood pressure. Okay, you have to know what blood pressure numbers you have to understand if you can. You'll have to understand if you need to treat that or not, or at least address it. You have to know that. You have to know your cholesterol numbers. Numbers can be your good cholesterol, which is your HDL, bad cholesterol, which is your LDL, or your total cholesterol, and your triglycerides. All of these numbers are things that you have to know. So if you push it to the side, and the other, I must say one other thing that you need to know is you need to know your what's called your hemoglobin A1C. That is a marker of how your blood sugar has been over the last 3 months or 4 months. I'm sorry, and
Gotcha.
120 days, and that number it gives you an average. These type of numbers that you have, these are kind of your own demographics that you have. Important, your birth date and your social security number should be the numbers of these. Now, granted, these change and these are dynamic, but you got to know those numbers before you can really start addressing it. Once you know those numbers and recognize that there may be an issue, a blood pressure over 140 and 80, 140 over 80, a blood sugar or the hemoglobin A1C over 6%, a cholesterol value, total cholesterol over 200, or a bad cholesterol or LDL over 130 and preferably over 100. We really need to understand that those are your demographics. That's you. We can address it by a number of ways, and we can talk about that. But in general, you have to know those numbers.
Oh, excellent. Should women be advocating for themselves differently? I mean, you're quite knowledgeable, and I love how you've just laid it out and to help me think about it differently and help the listeners think about it differently. Should women think and advocate for themselves differently based on that, what you're
Uh,
saying, and based on
uh,
what you know of the healthcare system?
That's actually a great question, and I'm glad you actually said that last statement. And I cut you off. I apologize for cutting you off because that was really important. Based on what I know about the healthcare system, that's a great point. There's a video out there that we've done, and we do it, but we show it at our meetings at the association. Shameless plug to the Association of Black Cardiologists, who I'm a proud member of.
That's all right. That's all
We
right.
there's a they'll have four patients or actors or actresses come in. Two men, women, black man, a white man, a black woman, white woman. Everybody has the exact same symptom. Whether it's
Gotcha.
discomfort, whether it's every time I walk, I start to feel fatigued, whatever it is. But they did it across the board, the same symptom. The doctors, now this is a doctor problem. The doctors
Okay.
more likely to refer the black man and the man and the black man to heart specialists or to heart testing for the white and black women. That's number one. That's a gender issue. Now, when it comes
Gotcha.
to race, the last one to be referred to a heart specialist or to heart testing was the Black woman with the same
Wow.
exact symptoms. So that goes to show you that that's what I meant. So I like your point when you say advocate for yourself.
Yes.
You say to your doctor, I recognize that heart disease is the number one killer in women like me. Not want to
Right.
blow this. I do not want to blow this off as menopausal, as I'm anxiety, as I'm histrionic, as whatever the excuse that the physician may, in their biased mind, think. We know that we need to have a heightened sense of urgency and a lower threshold of mind to be able to ensure that we don't miss this type of heart disease in women.
Excellent point. Excellent point. And I love the story because we all walk in with our own unconscious bias and biases all over the place. And so that leads me to this. I mean, I'm going to assume that by the time a patient, no matter what their color, particularly of women, come to you, they know they have a problem. Is there another way they should? I mean, what is the proper way of, based on what I know, by the time you're seeing a cardiologist, it's you got a problem. So so is there a way of engaging primary care physicians or other areas before they get to you?
So you meant from a patient standpoint, is there a way that what a patient could do? Well, I think it's well, we have two types of patients. There are always some very astute and concerned patients who will go directly to the cardiologist. The thing that we can do from a medical field is to ensure that our primary care physicians understand that, along with all the other medical issues that they have to deal with or that they have to know and treat for their patients, understanding that heart disease is still number one. So it needs to be at the top of the at your mind as a primary care doctor. So that goes with a lot of training for our primary care physicians, a lot of the PSAs, because the PSAs go directly to the public, and the public patient will
Yes, they
advocate
do.
for themselves and say, "Doc, you may be right. It could be all premenopause or perimenopause or whatever. But why don't we just think about maybe it's something else, and maybe I should see a cardiologist or at least be referred to some sort of the heart test." So there's a lot of factors that come into play there. I think that yeah. So there's a lot of factors that come into play.
Because you bring up a really good point as we meander through this podcast here is, when should someone see you? I mean, I mean, based on what I'm hearing, I would recommend that the loved ones, the women in my life, see a cardiologist the moment that they become post-menopausal, based on what I'm hearing. Do you have a
Good point. I think that I make the joke that if you have a heart, you see a cardiologist, but but that's really unrealistic. Care physicians can handle a lot of the preventative and primary care aspects of cardiology of heart disease, no question about it. I can tell you that nowadays we have such what we have to do, and this is what a doctor will do, and you can do this for yourself. Remember that there are risk factors that lead people to heart disease. Yes, there are always some rarities where this person has no risk factors and has some heart disease, which is very, very rare. In our mind, in the medical field, we are thinking when a person comes in, what is that person's risk for having heart disease? Primary care doctor does that as well. Does that person have high blood pressure? Risk factor. That blood pressure controlled or not? That person have diabetes? What was that person's vitamin A1C to know if it was controlled? That person have high cholesterol? What are those cholesterol numbers being treated or not? That person smoke cigarettes? Because that's another risk factor. That person have a family history of heart disease, such as their mother or father having heart disease before the age of 60. Whether that's blocked arteries and coronary disease, needing stents or bypass, or even having a heart attack before the age of 60. I think that's really the most important thing. So when you talk about those 5 risk factors, there's some other risk factors that exist as well, whether that's disease type of things. Put those in a formula goes in your brain as a patient as well as a physician, and you say, what is my likelihood of having heart disease? And the more of those risk factors you have, the more or the less controlled those these are, diabetes, cholesterol, and so forth, the more likelihood that that has led to plaque in your heart, and then now you are can succumb to heart disease. Way with stroke, that has led to plaque in your carotid arteries in your brain, and now you are more likely or more at risk for having a stroke.
Wow. And so is there talking about, you're an intervention cardiologist. And so, women, should they, is there a test to determine your level of plaque buildup?
So we guys the that look for the risk factors. Fortunately, over the last 10 years now, the advent of much better detection techniques,
Hmm.
are now able to recommend some sort of some other tests. The most tests now make the diagnosis of just plaque in the heart
Yes.
is something called a heart scan or a coronary calcium score. In other words, happens in your heart. You have heart's a big muscle. You have three arteries that give blood flow to it. Very similar to an engine that has fuel lines going into it. Imagine the fuel lines being inside the heart. Those are the coronary arteries. We now have a CAT scan that, interestingly enough, this is an insurance issue. Insurance doesn't cover this test. It's thought to be screening. It is a hospitals only charge $49 for it. What it does is it looks to see if there's any calcium in your heart arteries because that's what the CAT scan can see. Calcium is the
Gotcha.
calcium is the surrogate marker for plaque because plaque, as it develops inside of your heart muscle, inside of your heart arteries, and in the walls of the heart arteries or the coronary arteries, plaque starts to mature and it becomes calcium and calcified. Something that we can detect.
Ah,
So you did that test and you saw that there was no plaque or no calcium. The chance of you having plaque in the heart is very, very slim. You do see calcium in there. That is by definition, you do have plaque. Now, a lot of people that will have calcium and plaque in their heart arteries. The big question is that plaque actually obstructing the heart arteries or not? That's the question. Bit like a garden hose. A garden hose may have
gotcha.
a garden hose has a plastic portion that you may have calcium inside the plastic portion of a garden hose. But the water still flows nicely through there. Not a problem. You'll never know. But in the heart arteries, you have calcium within the walls, the arteries, which is also plaque within the walls. It can slowly impinge or pinch down the and reduce blood flow to the heart. Those are the things that cause heart attacks and cause heart problems. It's that plaque buildup in the heart that can
I
lead
see.
to heart attacks. So there are a lot of people who have
And what?
calcium. Say,
No, go ahead.
say there's a lot of people that have calcium arteries, but the calcium in plaque may not be obstructing it. But it does say by definition you have plaque. So now you already have a whole nother. You have risk stratified yourself into a different category. Risk of somebody with plaque versus somebody without plaque years away from each other. Okay. And now
Got you.
you are
And assuming you have plaque, is it reversible? Can be eliminated without coming to see an interventional no cardiologist?
not too many things that we've seen to reverse it. The goal, and I've come to this goal objective over the last 20 years, 25 years I've been practicing, is not so much to reverse it, is to keep it at bay, allow it to not
I
get
see.
worse. And there's also something called sensitive or vulnerable plaques that can cause heart attacks versus more mature and stable plaques. I think that's something that you're trying to do. And you're always trying to stabilize the plaque. You really can't get rid of it, but you can keep it at bay from becoming more plaque, as well as calming that plaque down so it doesn't cause any sort of problems in the future. One thing that I didn't allude to is that now you have plaque, just don't say, I'm done. Because you don't know if that plaque or calcium is actually impinging on the artery or not. Where you need some sort of functional test. See, the plaque was a structural or anatomical test, but now you need something functional, the functional, and that's where we start to bring in stress tests. Stress tests, it will tell us if the heart is getting adequate blood flow or not. That's what it is. So is that plaque impinging on the artery and reducing blood flow to the heart or not? And that's where we lead to stress tests.
And it's interesting. Are you finding that a lot of women are getting stress tests? Who's a candidate for a stress test? I mean,
That's exactly that.
based on what I'm hearing, the logically, I'm thinking you go ahead.
Go ahead, go ahead. Lodger, you're thinking what?
No, I was going to say logically, I know I have calcium, I have plaque, and women should be advocating for a stress test. It sounds like to me to answer the one question that you talked about to see if it's impinging on their heart.
That you have to advocate for yourself because now it goes back to that whole physician bias. Physician saying that woman comes in here. Many people that I've seen in my life are usually men. They're probably not going to be women, so she probably doesn't have heart disease. You see plaque, you see calcium, you've got to think that there's a chance that that's impinging on the arteries, or impinging on the arteries rather, and that is reducing blood flow. If that's the case, then you need that type of stress test, or you need a stress test to figure that out. So that's the next step, and you have to advocate for yourself. First thing you have to do is identify if you have heart calcium or not, and plaque. Although we will never ever be able to test the entire world this type of CAT scan.
Yes.
That's where the PSAs, that's where the next big things and those things come into play. Where we have to have people recognize that I'm getting fatigued more than normal. I'm getting some sort of chest discomfort, jaw discomfort, arm discomfort, usually left shoulder, neck, chest. Am I getting that when I am walking and then it goes away when I stop? Exert myself. Am I getting symptoms of shortness of breath? Am I getting symptoms of acid reflux? Am I getting symptoms of ear discomfort and neck, jaw pain when I'm exercising and then it goes away when I stop exercising? Is it happening when I'm resting and now it's associated with sweating and it's coming and going? That's that artery tight. It's narrow, but blood flow is able to get through intermittently. That's in off waxing and waning symptoms. That's really what's going to be the best approach here, is to ensure that the public understands that heart disease is it. And then also in the background, and this is the hard part because everybody always wants to think that they're healthy. In the background, do I have the risk factors for heart disease? Do I have high blood pressure? Do I have diabetes? Do I have high cholesterol? Did my mom have a heart attack at age 55? That type of thing, all of that comes into play. And when you have those risk factors and then you have the accompanying symptoms, it has to be thought that this is heart disease until proven otherwise.
Wow, this is interesting. So, asking a couple of additional questions before we run out of time. So, it sounds like women don't run into problems until menopause. Does hormonal
Not
replacement therapy
necessarily.
help?
That's a general rule. That's a general rule. We will
Okay.
always There are
What
always
about the
outliers.
menopause?
There are always outliers because
Yeah.
at the end of the day, a lot of times family history can really trump, for lack of better words, can actually
Yeah. Yeah.
supersede some of that. So we will get 40, 35, and 45-year-old women do have periods that are still menstruating, but have heart disease. So it can happen. But
I got you.
general statement is that typically you start to see it after the age of 50. And in fact, we used to we don't studies about maybe 15 years ago showing that you know what happens when you after menopause, your hormones change. So the way that women treat
Yes.
that is they start taking estrogen to get back to their premenopausal hormone levels
Yes.
so that they can control the hot flashes and those type of things. Well, we saw that estrogen caused problems postmenopausal person and heart disease way. So, we don't really suggest doing estrogen anymore like that. Now, and on and off causing heart problems, I mean, meaning that we've had data to say that it's direct link and some that says it's not a direct link, but that's just something to think about. But in general, though, the rule is that if you are postmenopausal, you have factors such as high blood pressure, diabetes, cholesterol, smoking, disease, those type of things. You have to, in your mind, think that maybe I am a candidate for someone who could have heart disease.
And with that, Doc, I want to thank you for being a guest on the show. And end with this one question. Are there preventative steps that these ladies can take? You've laid out beautifully some of the risk factors, but let's talk about preventative steps for a moment. Anything
So,
you can suggest from that perspective?
yeah, I can tell you right
Okay.
now. So, and like I said, I used to think that everyone knew this, but I was wrong, and it just doesn't know. Diet there is a clear link in diet and heart disease. Okay, no matter how we want, no matter how much we love our steaks and things like that, there's a clear link to it. So I think that the most important thing is trying to get as close to a plant-based diet as you can. I can tell you this.
Okay.
I can tell you this.
Okay.
I've been doing this 25 years. I've never seen a vegan with a heart disease, a heart attack. Not once.
I hate hearing that because,
You
but
do.
I love hearing it.
Yeah, I've never seen one yet. Now, our arguments that I get with my own colleagues, there are certain populations around the world that are vegetarian and they have heart disease. A lot of it is genetic based and so forth from their parents. But I'm telling you, practicing Chicago, primarily African American community, I have not seen a vegan have heart disease or at least blocked heart arteries. Okay, that's that. Goes past that.
Wow.
A vegan, vegetarian, pescatarian, and so
Yeah.
on. Okay, that's number one. Number two is we know that there is a clear link. There's a clear link to sedentary lifestyle. In other words, not exercising to heart disease. Okay, come up with some suggestions for the type of exercise you do. And you would think that it's jogging and running on a treadmill at high speed with a high incline. It's not.
Yes.
It is a flat walk for 45 minutes at a time, continuously, or 4 times per week. That's all. And
Okay.
that's doable. That's doable for a lot of people.
Yeah, it is.
Can't walk, always do the stationary bike and those type of things. But in general, we do know that the sedentary lifestyle, the opposite of exercise, is a clear setup or at least a risk factor for heart disease. Know that you have unfortunately, you have the diseases such as high blood pressure, such as diabetes, such as high cholesterol, need to be under control. Diabetic needs to
Yes.
have their hemoglobin A1C at the level of a non-diabetic. It's doable because I've seen it before. You can get those
Okay.
numbers down. You
Okay.
can get those blood sugars down by it and by medications and by weight loss. A number of things you can do. Blood pressure, somewhat, I would say, some argue it's genetic. I can tell you that a large amount of people especially African Americans, have high blood pressure. No question about it. There have been some
Hmm.
estimates as high as
Hmm.
60 to 70% by the time they're age 60. Okay. That being said, we have to identify if there's high blood pressure and treat it. Okay. That cholesterol. Nobody wants to take a medicine, but 25% of your cholesterol is dietary. 75% is what your body overproduces. So yes, you can be a vegan and a vegetarian and still have high cholesterol because it's not all dietary. And when that happens, where we have great medicines that can actually calm that down get it down to normal levels, what we believe are normal levels. And there's more benefits with the cholesterol medicine than just lowering your cholesterol. There's a lot of anti-inflammatory, antioxidant type benefits that we see. We call them the pleiotropic. There are other um, other types of benefits than just lowering your cholesterol. So those are things.
Got you.
Away from tobacco products. Okay, stand away from tobacco products. Controlling your stress. Okay, stress leads to higher blood pressure, higher blood sugar levels, leads to heart rates. When you're not doing anything. Okay. Uh, Another one is understanding a phenomena called sleep apnea. Apnea means that you stop breathing when you're sleeping. And you may not know it, but your partner may know it. And your partner may say, "Boy, does this person snore?"
Right.
During the snoring episodes, you recognize they're not breathing. From the mildest cases of sleep apnea to the most serious ones where people are stopping breathing for minutes, over the night at a time.
Yes.
150 times for 12 seconds at each one. That adds up. You're bound to not do well if you're doing that every day. Your adrenaline's going to be up. Your blood sugar's going to be up.
Absolutely.
Everything's going to be up.
I
So
get it.
sleep apnea is one of the causes now that we see is directly links to heart disease and heart attacks for sure. So those are the things that we have to do. Recognize symptoms, recognize disease, keep them under control, and eliminate the negativities, the negative of your life that may lead to heart disease.
Well, Dr. Everett, I want to thank you so much for sharing your time and your expertise with us today.
You take care.
All right. Bye now.